Welcome everyone. Hope you are ready for a heart-to-heart discussion today about your heart health. We are lucky to have cardiologist Dr. Abdullah Haddad with us. Dr. Haddad is a non-invasive cardiologist with expertise in diagnosis and treatment of coronary artery disease, vascular abnormalities, abnormal heart rhythms, and heart failure. He has a strong educational background at Mayo Clinic, Harvard, Temple University Hospital, and Allegheny Health Network. He has been published for his work in valve replacement, artery repair, and heart disease with board certifications in internal medicine, cardiovascular disease, echocardiography, nuclear cardiology, and cardiovascular computed tomography. Today, he is sharing that expertise with us, as well as answering your questions live. If you have a question for Dr. Haddad, please text me. Text, don't call, 248-935-2562. You can also submit your questions on Facebook or YouTube. Dr. Haddad will answer your questions live right after his presentation. Dr. Haddad?
Well, thank you very much for having me today. I would like to discuss a topic that's near and dear to my heart, which is prevention of cardiovascular disease. So first of all, what is cardiovascular disease? Let's think about this large umbrella that has multiple conditions that falls underneath it. Conditions such as stroke, heart attack, abnormal heart rhythms, heart failure, peripheral vascular disease such as aneurysm or occlusion in the arteries such as carotid stenosis, or even abnormal valve functions of the heart. So when we discuss the risk factors for cardiovascular disease, I always like to look at them in two different main categories. Modifiable risk factors, there's nothing we can do about them to alter the course of them, and modifiable risk factors. The non-modifiable ones, such as one's getting older, aging, one's gender, race or ethnicity, and the genes that we inherited from our family. However, in terms of the modifiable risk factors, I normally try to look at them in two different groups or subgroups. Ones that can relate to the person's habits or habitual risk factors, such as smoking, alcohol, the lack of physical activities in addition to poor diet, and the other part of that subgroup, we call them the condition risk factors, the medical conditions such as one's medical condition of obesity, diabetes, high cholesterol, and elevated blood pressure. It's really important to recognize that 80% of the cardiovascular disease stem from these modifiable risk factors, that we have the power to change them and modify them if we try hard enough. So the first one we'd like to talk about today is hypertension or elevated blood pressure. We get asked a lot in the clinic, what is normal blood pressure? Normal blood pressure, per the current guidelines, is less than 120/80. So whenever we see patients in the clinic that have they have blood pressure above 130 systolic or above 80 diastolic, this is actually fits the diagnosis for high blood pressure or hypertension. It's important to recognize the numbers that between this normal value and the high value, which is actually systolic blood pressure between 120 and 130, or diastolic numbers still less than 80. So we should treat these similarly as we treat pre-diabetes patients with like mildly elevated hemoglobin A1C, because this is really our chance to change one's behavior, maybe lose some weight, like follow a better diet, exercise some more, so you don't eventually fall into the high blood pressure category and you go back to normal blood pressure readings. And obviously, as this slide show, the blood pressure has different stages, and as the blood pressure gets higher and higher, there's a more urgent need to get the blood pressure under better control. For those who run blood pressure above 180/120, they should seek immediate medical attention because they are at especially high risk to have dire consequences such as hemorrhagic stroke or congestive heart failure episodes. So hypertension, again, is very important because it's responsible for most of the cardiovascular events, or more cardiovascular events than any other risk factors in the modifiable risk factors group. It affects about 1 in 5 adults in the United States, and has tendency to affect more African American population than the rest of the population in the United States. And unfortunately, only 1 in 5 or 1 in 4, patients with high blood pressure, they have the blood pressure well controlled, despite us in the medical field spending more than north of $100 billion a year to treat hypertension and its related consequences or conditions. The hypertension doesn't only affect the heart or the brain, but also affect one's vision, could lead eventually to vision loss if there's no adequate treatment or tight control of the blood pressure, could affect also the person's kidney function, end up costing the patients their kidneys, and they will end up on hemodialysis, and in addition to sexual dysfunction as well. So whenever I see a patient in the clinic that we know the blood pressure that's elevated, I always ask the patient if they do check the blood pressure at home. And if they do, I always ask her about what's the blood pressure average at home, and counsel the patient about the proper way to check the blood pressure, because they normally should be sitting down for a good 5 or 10 minutes in a quiet environment, then put the blood pressure cuff. I usually recommend the one around the biceps or the upper part of the arm. These tend to be more accurate than the ones that are on the wrist or the fingertip. And check the blood pressure. For those who especially who has hypertension, ask them to check the blood pressure multiple times a day and establish a log. And this is important for us to know what's their average blood pressure throughout the day in order to make changes to the medications if needed. A question we get asked a lot in our clinic, if we have any blood pressure machine or blood pressure cuff brand that we normally recommend. I normally refer the patients back to a website called Validate BP, and it's a website where you can look at the brands that have been validated by the medical societies and make sure that the one you have at home fits the description. If you don't, maybe you can actually purchase one of the recommended one to make sure that you have an adequate and accurate blood pressure readings for us to be able to make appropriate changes, medications actually in a timely fashion. So, and what's interesting, for most of the patients that we see in the clinic that they do not have adequate blood pressure control, the reason is because they don't take their medications the way they should be taking them. It's studies have showed that about 50 to 80% of patients are not adherent to their medications. And this could be obviously because of various reasons, either side effects or maybe too cumbersome, or the person is on too many medications. Obviously, if this is what's happening with the patient, they should check with their providers in the near future. Because obviously if you're having any side effects from the medications, you can easily swap it with another blood pressure agent. Or maybe maybe you could ask your provider, if you're on a medication that you have to take multiple times a day, if there's any equivalent of this medication that you take only once or twice. And there are even blood pressure medications out there that have combined pill, more than one agent in one medication, so it can be easier for you to take it, in the long run. And the second risk factor I would like to discuss today is the hyperlipidemia, or elevated cholesterol level. And the picture here that's shown on the slide, this shows a cross-section of the lumen of the vessel. The wall of the vessels shows in the pink color, and the yellow or orange color plaque, that's just a cholesterol accumulation on the walls of the vessels. And throughout time, this cholesterol plaque or accumulation gets worse over time if you don't intervene early enough, to the point called significant narrowing in the vessel, and in some cases could actually cause something called acute plaque rupture and lead to heart attack or acute stroke. And it's important to recognize this disease early in the process, because nowadays we have medical agents that could either stop the progression of the cholesterol plaque or even slow it significantly. And so we've been actually able to transfer these kind of atherosclerosis or plaque from something the patients they die from to something the patients they die with. And whenever you meet with your provider for your routine exam, or if you have visit for any other reason, always make sure that you have routine cholesterol level or lipid panel checked. And us as a provider, we look at them and we use a couple of other tools to determine if the person or the patient, they need to be on cholesterol-lowering agents. We use something called a pooled cohort equation. That it's a risk estimator that gives us the chance or the risk of the patient having a cardiovascular event within the next 10 years. If it's above a certain cutoff, then this triggers a discussion with the patient about being on the cholesterol medication. In addition to that, the current guidelines recognize what we call them risk modifiers or enhancers to somebody who has mildly elevated cholesterol level. So we don't just target numbers, we just target actually other risk factors in terms to come up with a more personalized medicine rather than just like one size fits all. So some of the risk enhancers that we always look for if the person has any family history, first degree relatives such as mom, dad, or siblings who have premature or early heart disease or heart attack. And the others could be maybe some inflammatory state, especially those who has lupus or rheumatoid arthritis, patient with HIV, it's especially high risk to have atherosclerosis that progresses fast to the point actually ends up with an event, and in addition to the patient who smokes or have chronic kidney disease. So these patients, they should be considered more closely to be on medications earlier, despite maybe having slightly elevated cholesterol or lipid or LDL level, which is low density lipoprotein. The next risk factor, which is actually a habitual risk factor we'd like to discuss today, it's the active lifestyle. This is a pie chart of the average hours spent per day in U.S. adults. And this is obviously doing various activities between sedentary activities, sleeping, light work, and moderate or vigorous activities. What's striking that this is like a small sliver of a slice in the red color. This actually represents how much time we spend in adequate level of exertion that could protect us from having cardiovascular disease or cardiovascular disease. And it's almost like an average for U.S. adults about 6 to 10 minutes a day, which is not quite enough. The reason, because the current guidelines, they recommend at least 150 of moderate intensity exercise accumulated over the span of a week. So if you exert yourself or are active, it should be technically 20 to 25 minutes a day to be able to reach the 150 minutes cutoff. However, for those who exercise more routinely or more vigorously, they can cut that down, cut that time actually in half to at least 75 minutes of vigorous activities. And a lot of times, actually, when I ask patients in the clinic if they're active, they tell me let's say they walk around the block with their spouse or significant other, they walk their dogs actually a couple times a day. So for those patients, I usually tell them, this sometimes not quite enough, and the way to know that this is actually counts, you can count this kind of level of activities to your daily activity levels that you need to meet, that you at least need to meet on an everyday basis. You need to walk at a pace that's fast enough you're barely able to keep up the conversation, and this is about equivalent to a brisk walk for about 2.5 to 4 miles per hour. For those who has joint or back issues, we recommend maybe stationary bike or use recreational swimming or underwater aerobic activities. Should actually 20-25 minutes a day should be able to add up throughout the week to more than 150 minutes. And obviously those who exercise more vigorously, such as jogging, running, or single tennis and swimming laps, they need at least more than about 10 to 15 minutes a day to hit that target, the weekly target of the minimum level of activity or exercise. Next is it's a factor that's a lot of times actually overlooked just because the way we live our lives nowadays and everything is a fast pace. So we need to pay close attention to our diet. We always counsel patients that are at risk or already have cardiovascular events to avoid red meat as much as possible, eliminate and avoid by all costs processed meats, and maybe replace them with the lean protein, either animal or plant-based. That should be okay. Increase daily servings from fruits, nuts, vegetables, and whole grain as well. And for those who suffers from for those who suffer from obesity or overweight, they're recommended to start caloric restrictions where they can achieve and maintain weight loss. And last but not least, this is a website that's sponsored or created by the American Heart Association, and it's aimed for those who would like to read more about the risk factors we just discussed today, or even delve into other risk factors we haven't had a chance to cover today. And also, not only that, but also they have tips and about how to read the nutrition labels on the food that we purchase from the grocery store. They have recipes for the patient to maybe cook a healthier or heart-healthy diet, and they also have exercise programs and support programs as well. And this is obviously free of charge. And that's all I have for you today. Thank you very much.
Okay, great information. There's still time to get your questions in. You can text them to 248-935-2562 or submit your questions on Facebook or YouTube. The first question that came in is, should I be taking a low-dose aspirin to help my heart? I'm healthy, just turned 70 years old.
It's an excellent question. This used to be a common theme or recommendation back in the days. However, nowadays it's not the recommendations anymore. It's more, again, we're trying to move away from one size fits all. We're trying to practice more personalized medicine. So without knowing that person's exact risk factors profile, the comorbidities that they have, it's very hard to give a specific recommendation. But definitely counsel with your provider to see if there's any indication for low-dose aspirin. The recent study that published a few years ago showed that probably if you take it if the general population takes aspirin prophylactically, there's more events, bleeding, meaning consequences from taking the aspirin, than protection that the aspirin provides for the general population. But this should be done on case-by-case basis. That's an excellent question.
That kind of leads into a different question. Do you see a cardiologist only if you're having issues, or should you start seeing them at a certain age as a baseline? Or
honestly, there's no age cutoff in my opinion. There's more obviously symptoms. Definitely see a cardiologist if you feel like that your needs are not being met by your current provider. But if you have enough risk factors, from the slides that we showed earlier, if you have enough risk factors and you're worried about your future event risk, then definitely actually this is a good enough reason for you to meet with a cardiologist to talk about these risk factors, to tailor your medication a little bit more, to have your blood pressure better controlled, have your cholesterol a bit more controlled, so you would know what to expect, what to do next.
Scott says that he's had angina for more than 3 years. His cardiologist wants to do a stress test, but he's still having chest pain, and just kind of wondering if there's anything that he can do about that.
So I think it sounds like to me, from obviously not knowing what Scott's medical condition exactly and if he had any prior testing, if somebody's having what we call stable angina, meaning it's just chest pain that's been going on for a while without change, especially exertional pain that happens, meaning with a certain level of activities, then goes away with a few minutes of rest, we call this stable angina. And proceeding with, we call this ischemic workup or functional study, is really reasonable, and we do this actually a lot in cardiology. But obviously if Scott or somebody else is having acute onset of chest pain, this chest pain just started now, where they woke up with a chest pain, it's not time to consider a stress test. It's probably time to come to the emergency room to make sure they're not having an evolving heart attack, to get checked out for that, obviously.
This question is, I'm a 45-year-old woman in good health. My father and older brothers all have had heart issues. Should I be screened for heart disease?
It's an excellent question, and we get this actually a lot in our practice. You said she's 45?
Yep.
Okay. So there are population studies done on patients that have no symptoms, similar to this story that you just told me, but maybe with some risk factors, meaning maybe family history of heart disease. Nowadays, these patients, we recommend something called a calcium score for risk stratification. And it's a calcium score, it's a low radiation CT that takes a look at the coronary arteries and to see if there's any calcium deposition on these arteries. And if there's more than certain cutoff, then the person will have a strong indication to be on statin therapy or medication to lower down the cholesterol. And and the radiation, by the way, the radiation exposure from this scan is about the same amount of radiation she will get from a mammogram. And this is a study that's done maybe once or twice in the person's lifetime. So you do it, we recommend it at the age of 45 or above, and you do it once. If the score is 0, meaning there's no calcium at all, then you repeat this test in 5 years. If it's 0 again, that person's risk of having a cardiovascular event is extremely, extremely low, and they probably won't have a good indication to be on statin therapy. However, if the person that submitted a question, they have family history of premature heart disease, meaning actually a heart attack or stroke that happened early in her first-degree relatives, mom, dad, or siblings, we might have to go through a different route. So without knowing the exact age, I cannot give tailored answer to the person. But in general, healthy individuals, age of 45 or above, who would like to know the risk of having a cardiovascular event, calcium score is a great tool that we can use.
If it's determined that I need a stent, how long is the recovery period?
Well, I'm assuming that stent they're talking about is a coronary stent, because there are obviously stents that goes into the aorta. There's stent that goes into the carotid artery, the legs, and the additional coronary arteries. If it's a coronary arteries, usually, if it's done for stable angina, a lot of times we bring the patient over to the hospital, they get a procedure done, they go home either the same day, or sometimes actually they go home the next day. So the recovery is pretty quick.
Are there different heart attack symptoms for women?
So women could have atypical chest pain, or atypical angina as their indication actually for coronary artery disease. They the textbook description for angina is just a substernal chest pain in the middle of the chest that's pressure-like, like somebody's sitting on my chest. Then maybe sometimes radiates to either the jaw or the neck or the left arm, and usually happens at certain level of exertion and goes away with the rest. Women might have a little bit different. They might have only the neck pain or the arm pain with exertion, or maybe like left-sided kind of pain, or sometimes even shortness of breath, especially in patients who have diabetes. So yes, women could have like slightly atypical symptoms compared to their peer men.
Okay, that's our final question.
Okay, awesome.
Great information today to help you with your heart health. If you'd like to make an appointment with Dr. Haddad, you can call 810-600-3399 or head to hurleymc.com. Your heart will be in the right place. We'd like to thank Mid-Michigan Now for being great broadcast partners for this presentation. Have a great day, everyone.